Ulcer debridement and related compression. Ulcer debridement consists in removing of necrotic and/or damaged and/or infected tissue to improve the healing potential of the remaining healthy tissue. We distinguish ulcer debridement in autolytic, mechanical, enzymatic, biological, and sharp. That means surgical or hydrosurgical. Autolytic debridement is the lysis of the damaged tissue at one side by means of body-owned enzymes that are able to rehydrate, soften, and finally liquefy hard eschar and slough. Autolytic debridement is selective as only necrotic tissue is liquefied, and it can be favored by using dressings such as hydrocolloids, hydrogels, alginates, hydrofibers, and foam dressing that keep the wound bed moist, and this helps the autolytic debridement to occur. Mechanical debridement is completely different because with this system we mechanically remove necrotic or infected or tissue or fibrous slough, and this can be performed with a very simple way, wet to dry. That means to put some wet gauze on the ulcers. When the wet gauze is dehydrate and essiccate, they can be removed, and by removing they take away all the necrotic tissue. It is quite painful. Otherwise, we could also use ultrasounds and systems based on water. With this system, we are able to wash the ulcer bed with water under pressure, and this mechanically removes necrotic debris and fibrous slough. Enzymatic debridement is another kind of debridement. In this case, we apply a cream based on enzymes, and then more common enzymes are collagenase, catalase, or papain, and with this cream we cover completely the ulcer. Enzymatic debridement, I would say, has two problems, both from the patient perspective and also from the healthcare personnel perspective, because the enzymes are quickly deactivated by the ulcer fluid, so they need to be renovated every 8 to 12 hours. That means 2-3 times per day. And this is very time consuming for health personnel and maybe painful for the patient that need to be dressed 2 or 3 times per day. And this is not comfortable for them. Sharp debridement is certainly the quickest way to get an ulcer debridement. We obviously can do this just for large ulcers, deeply necrotic or infected. It is necessary to do this in the surgical theater. It is very quick, and particularly with the hydrosurgery, the debridement can be very selective, and the ulcer bed can be really effectively prepared for an skin grafting. Compression in ulcer management. As the first pathophysiologic factor in venous ulcer is venous hypertension, obviously the most effective compression modality will be the most effective in reducing venous ambulatory hypertension. And this means that inelastic compression, bandages or adjustable compression wraps, that are the most effective compression modality in reducing ambulatory venous hypertension, should be the most effective modality in ulcer treatment. And actually, they are recommended by all the most recent guidelines, like the guidelines of American Venous Forum and Surgical Vascular Society. They were confirmed by IUP comment. Also, the Cochrane review recommends strong compression. And UMA, this is the last guideline we have, again recommend strong compressor for ulcer treatment. Unfortunately, we have many reports on superior or similar effect of elastic kits or elastic stocking when compared with inelastic bandages. And all these papers are nicely summarized in a meta-analysis published some years ago. But all these papers have many flaws, many methodological flaws, because compression pressure, which is the dosage of compression, is never measured, and what kind of pressure it is exerted is completely unknown. What kind of bandage was used, we don't know. Elastic or inelastic, we don't know. Who applied the bandage, the level of expertise, and we know that level of expertise is a crucial point applying inelastic compression. If the patient was adherent to treatment, or if, for instance, if they were allowed to remove and reapply the bandages by themselves, all the unwanted effect, tourniquet, slippage, rolling are not known. As a kind of example of this comparison, you can see here the first publication comparing elastic kit and inelastic bandages, and you see here that even from the enrollment there are some mistakes because the ulcer area, the ulcer surface, and the ulcer age in the elastic kit group was smaller, the ulcer surface, and the ulcer age was different, much lower, much shorter, compared to the ulcer that were in the inelastic group that were significantly larger and significantly older, I mean long-standing. And even more important, with the two compression devices, amazingly, the pressure applied with inelastic bandages was lower than that of an elastic kit. And so it is completely clear that the elastic kit was more effective than inelastic bandage, but just because inelastic bandages were poorly applied. And paradoxically, this study confirms that inelastic compression is more effective than elastic stocking, because if you apply inelastic material properly, the pressure will be much higher, the exerted pressure will be much higher. And in this case, a higher pressure will produce better results. So it can definitely happen that a good elastic stocking or kit were compared with a poorly applied inelastic bandage. When compression pressure is measured and inelastic material is correctly applied, inelastic compression is very effective and more effective than elastic stocking. And this can be clearly shown by one of our publications. We compared actually not elastic and inelastic material, but two inelastic material. But what is important to see is that applying correctly these two bandages, the healing rate at 3 months is extremely high, more than 90% in both cases, which is an extremely good result. And again, comparing instead elastic and inelastic material with an elastic material properly applied, you see that the healing rate is higher with inelastic material. Elastic kits are anyway effective, especially when used in small and recent onset ulcer. If you see all the study comparing elastic and inelastic bandages, elastic stocking and inelastic bandages, we can neglect the comparison and just concentrate on the ulcer rate, healing rate of the elastic kit. You can see that the healing rate is quite nice, and there is an average at 3 months, 64% of ulcer healed, even with the elastic kit. But this was with small ulcers and recent onset ulcers. Adjustable compression wraps is a new frontier, so to say, for ulcer treatment. We performed a multicentric study in Italy, and we compared an inelastic bandage, the double layer, with an adjustable compression wraps. And you see here that the healing rate what we got with the adjustable compression wrap is higher than that of inelastic bandages. The difference is not significant, but we're not surprised by this because our primary aim were costs, and this was just a secondary aim, and the not significance is just because of the sample size that was too low to have a significant difference regarding healing rate. Regarding costs, there is no way. The costs are much lower with adjustable compression wraps because you need just one device for all the ulcer treatment, while with an elastic bandage you need to change the bandage and to throw away the bandage every week, and this obviously is expensive. So take-home messages: facing with venous leg ulcer, particularly if hard to heal, an effective debridement and the correct compression therapy may speed up the healing process. Debridement can be chosen based on the ulcer bed condition, from a gentle autolytic debridement in the ambulatory setting to the sharp and painful debridement to perform under general anesthesia in the surgical room. For compression therapy, inelastic material, both bandages and adjustable compression wraps, should be preferred to elastic material. When applying elastic bandages, education is strongly required, and elastic kit may be used in small and recent onset venous leg ulcer. Thank you very much for your attention.